Welcome to AETCM. Today we're going to discuss a case about an 8-year-old child who was brought to
Eight. Okay.
8, sir. 8-year-old child who was brought into ER with complaints of cough for the past 3 days with associated with nasal congestion, fever and breathlessness since one day.
Yeah.
Shall we begin, sir?
Yeah, please.
On initial assessment, the child was conscious oriented in patch triangle. On appearance, the child was interacting with us, and she was talking to us, and her gaze was towards us, and she was also there was no she was not crying as such. And in work of breathing, there was she was having increased tachypnea. Other than that, no signs of any stridor, no wheezing, no obstruction signs, no abnormal posturing, no retractions were noted. And in circulation, there was no signs of any cyanosis, pallor, modeling noted, sir. Sir, in airway was patent. No secretions were noted in the oral cavity. In coming to breathing, air entry was bilaterally equal. Bilateral scattered creps and occasional wrong was heard, and respiratory rate of 36 per minute. And saturation of 99% was maintained in room air. In circulation, pulse rate of 100 per minute was maintained, and all peripheral pulses were palpable. In disability, GCS was full with the pupil equally reacting to light. And in temperature, GRBS of 100, and temperature of 100 degree with,
Okay.
With the GRBS of 100 milligram per deciliter, and patient she was covered.
Yeah. So can you just summarize the positive findings in so far?
Positive findings was she was tachypnic, and then
How do you calculate the respiratory rate for the age?
for age, so child is 8 years, so in that age usually the respiratory rate will be between 15 to 25.
Binu? I don't know if you can say.
So for pediatric age group, it will be differs from age, sir. In newborns, it will be like 60, 50 to 60, 40 to 60 would be the range, and as age increases, the respiratory rate comes down. Since it's 8 years old, it will be around 20. 20 to 25 will be the range for respiratory.
So suppose it's an infant, it will come around 30 to 60. As the age advances, the rate will come down. So about like around 0 to 3 years, 1 to 3 years will be around like 24 to 40, and above that it will be like from 22 to 34, like that. Above 20 years will be more like an adult age, like around 12 to 16. So coming to this age will be around between 22 to 34 will be the expected respiratory rate. So the child is considerably slightly tachypnic, like 36 to 40 will be the current rate.
So we were eliciting history from the child himself or herself, or you get the history from the...
Sir, his mother was there, sir.
You talked to the child, you told. You are talking to the child. Pat triangle. So from the talk, what are the things can you assess? The child, 8-year-old, having breathing difficulty, known case of asthma. So you told the voice, first one is voice. So whether a change in the voice, husky voice or anything. So that will give a clue whether there is any glottic edema or voice changes. Number 2, whether he is able to complete full sentence in normal tone. Full sentence. They are having, especially in asthmatic patients, they will tell 2-3 words, then they will stop again, break again, they will be continue. So breathing difficulty, this one, say that, okay. And then retraction. See, what are the things he will be look for?
Retraction.
Chest retractions, you have to look for in sternal, supraclavicular area, between the ribs, infrascapular area, intercostal areas.
And then
Abdomen.
Okay, these are all things you have to look for. Temperature is 100 degrees Fahrenheit or centigrade. Is it always mentioned the unit? Pardon?
I'm
You
sorry,
told
sir.
100, 10%.
Okay, okay.
That is okay, no problem. Just for your this thing. Okay, good. Carry on.
Okay, correct.
Sir, in adjunct to primary survey,
Heart rate you mentioned?
heart rate was 100 per minute, sir.
Okay. And heart rate also any range or anything as per
Sir,
age?
this also varying according to age, sir. Initially, but neonate may have range between 100 to 180.
120.
Is there any formula or anything?
So for 8 years old, it will be up till 120 to
120.
130 will be considered to be normal.
Okay.
In kids, it can go up till 150. Yeah. So 8 years old, it will come up to 120.
80 to 120.
What are the other signs of increased work of breathing?
So one will be obvious tachypnea, or the child will
One
look
is
sad.
tachypnea.
Then child will look sick or cyanosed. Peripheral cyanosis everything will be there. Then we'll
Where will you look for cyanosis?
Lips,
First
tongue,
choice is the
oral mucosa.
because of the conjunctiva as well as the lips and tongue. Okay.
Then from the appearance there will be nasal flaring. There may be
Nasal flaring, one of the most important things.
Then retractions can be substernal, intercostal, then
Retractions.
retractions will be there. Then tripod posturing may be there. And also when the child starts talking, she will stop adaptively because she want to take more air. It could be one thing.
And accessory muscles of respiration.
Excessive
That will be
suppression.
active. These are all things.
Then also any audible stridor or wheeze also gives like
Okay. So what is the cause for the tachycardia?
One, it can be secondary to the anxiety or to the fever,
Fever
and child is scared.
and respiratory distress itself.
Or
Okay,
asthma
these are all
itself
these
can
things will
cause
produce.
tachycardia.
Okay, carry on.
Yeah. Proceed.
Yes, sir. Carry on.
Sir, in adjunct, we did an ABG, sir, was showing mild.
History. After that, okay, carry on. You go in your order. Good.
Okay, sir. We did an ABG, which shows a pH of 7.47 with PCO2 of 30 and bicarb of 27. Mild alkalotic picture was seen, sir. And other than that, we'll be going.
PO2 is important, no, in this patient?
PO2 was
90.
98, sir.
Indeed. On room air.
98.
On room air. Okay.
In secondary survey history, sir, she's an 8-year-old child, known case of bronchial asthma, and a past history of adenotonsillectomy at 3 years of age. Now came with complaints of cough with nasal congestion since the past 3 days, with the intermittent high-grade fever and one episode of vomiting was for the last 1 day with breathlessness, and she was also complaining of occasional cough also. There was no allergic history noted, and she environmental history, social history was normal, and she was taking medications of Budicort, MDM was taking, and also Astarin MDA was taking. In general examination, she was thin built and nourished, and
Okay. Just we'll hold on here. So basically, she has somebody, 8-year-old kid who has been already labeled as bronchial asthma and already on MDI. So how will you diagnose asthma in children? Anything different from adults?
Even asthma, it is very difficult to diagnose in children, especially if a child presents with wheeze or tachypnea at least up until 2 years of age. Bronchiolitis has to be thought of and not asthma. And following this, again, if the patient presents with wheeze, it will be virus-induced wheeze. So asthma only after about 4-5 years of age, and the patient continues to have wheeze is when, and if a strong family history is there, plus obvious dust allergy and all of that, is when we go with PFT and then diagnose the patient with asthma.
Okay.
So
all,
there's a strong precipitating factors, we don't diagnose a child with asthma.
Yeah, from primary health perspective, but anyway, child is not going to be cooperative for PFT and all. So that age cutoff is definitely there. A surrogate thing will be a response to bronchodilators. So if the patient usually responds to inhalational bronchodilators, that for that age group can be tentatively considered as bronchial asthma, but in due course has to be confirmed with the PFT as the child grows up and becomes cooperative. Okay. So
And the duration, how long the child is suffering from this one, number one. How long? What time?
She was having the symptoms from the 2 years of age, sir.
From 2 years, okay. See, any recurrent attacks in the recent past which needed hospital or ICU admission?
Yes, sir. She had a similar complaint 1 month back also.
Okay. And the drugs, last dosage?
MDA was 200 microgram, Budicot MDA, and Astalin of 100.
Recently, half an hour, 1 hour back, before reaching the hospital, if the child has taken this medication, definitely we may be having a chance. The child will be having a good amount of oxygenation and the symptoms may be less. So this is also looking good.
and any other implication of inhalational bronchodilators on vital signs, especially with Astalin?
That it will cause tachycardia.
Tachycardia.
And
No, Budicot and salbutamol. Yeah, continue.
Yeah, weight of the child was 30 kg, sir. And general examination weight of the
That
child.
is an absolute number doesn't matter. No, what is the BMI?
it will fall between 8-year-old child. 8 kgs is fall
Is it
between
appropriate
the
or
10
not?
and 20%.
Okay, tell in BMI terms so that we can get an idea. Okay.
And repeat examination, there was pulse rate of 98 per minute and respiratory rate of 32. And saturation of 99 maintained in room air. In systemic examination, respiratory system was showing bilateral air.
So what else will you ask in the history? The child is having fever, 2-3 days fever.
Yes.
See the cough, whether it is wet cough or dry cough. Is there any productive secretions or there? So that also goes along with the treatment aspect. Number 2, feeding. Whether the child is taking good amount of feeding and hydration. This will be reflected in the urine output. So we should any fever or temperature, deprivation of fluid, always you concentrate on the urine output also. It's the most important. 2 things are important in the perfusion, whether it is good or not. One is central function. There is mental status. See, hypoxia or hypoperfusion, definitely there will be altered mental status apart from so many other causes. Then urine output, clinically it's a good monitor about aside from intake and then any need for fluid replacement. And then in the children especially dehydration. Any features of dehydration is there. See, tachypnea, what will happen? Lot of water loss will also be there. Respiratory passage will be dried and the secretions will become more and more thick. So we have to loosen the secretions appropriately with medications. All these things, when the therapeutic aspect is concerned, we have to keep everything in mind.
Immunization also.
Pardon, ma?
Immunization of the child.
Yeah, immunization.
Vaccination.
That is well. And family history. So asthma family history is also important. Good. Yeah.
Yeah.
Okay, sir. Respiratory system bilateral. Respiratory system bilateral scattered crepes were noted, and Ronge was also noted on systemic examination, sir. And the other systems were within.
What does Crips denote? What does wrongly denote?
Bronchi is basically obstruction.
Narrowing.
Narrowing of air.
Cryptations is when the alveoli that doesn't
Lot of
open.
secretions.
Secretions.
Collections.
Collections,
Fluid.
mucus,
Okay.
exudate.
So then the lung is wet. So most probably they will be having
Infection.
only dry and asthma elements. Ronchi will be more. Okay, good.
Other systems were within normal limits, sir. And following which she was having the symptoms, we started her on nebulization, Astalin and Astalin initially, and also she was having fever. We did give her paracetamol tablet also. Later on, her repeated cycles of Astalin was given, and her breathlessness was reducing, and we also give her nebulization of Ipravent also along with it, sir. Yeah. And following which she was becoming, her tachypnea was reducing, and later on we did a chest x-ray and lab investigations were sent, sir. And lab investigation results, we got showed a total count of 15,000 with CRP of 7, and other platelet count of 3 lakh, and other counts were within normal, sir.
That's it. Okay, so there are certain things here. So one is, it's not very convincing or fitting in completely to a bronchial asthma exacerbation alone. Okay, one. Second thing, we need to kind of assess for other causes of wheeze in children. So what are the other causes for which a child should can present to ER with wheeze?
Bronchiolitis.
Okay.
2-year-old.
2-year-old child.
Then
And
Any foreign body
good.
can cause wheeze. Basically, any obstructions and any
Yeah.
infection also can cause. Apart from exacerbation of asthma, even pneumonia can cause wheeze. Then especially in an 8-year-old child, foreign body has to be thought of.
Yeah, acute allergic or anaphylaxis.
Allergic,
Yeah. So always think about certain causes which are age specific. Okay. Other common causes for elderly will remain, but these foreign body, bronchiolitis, tracheobronchitis, kind of tracheomalacia, those kind of DDs also you need to keep in mind. Okay. Fine. So here definitely it is looking more like a background probable bronchial asthma with an acute infective exacerbation kind of scenario. Okay. Now the patient is coming and you are giving the patient the initial line of management. What are the usual signs which will indicate a sign of an impending respiratory failure?
patient will be an initial assessment, child will be appearance will be drowsy.
Okay. One is sensorium, change in level of sensorium. One.
She she will have, there may be inconsolable cry, or she won't be even responding to us.
Okay, that's sensorium, various levels of altered sensorium kind of thing. Then cyanosis.
Cyanosis will be
Okay.
there.
What about carbon dioxide? What happens?
that builds up.
Yeah. So initial phases you are going to get a PCO2 washout, but the moment you are seeing a PCO2 build up, that is a very very early indicator of an impending respiratory failure, and that itself should alert you to keep your airway equipments ready. Okay. Anything else?
Silent cough, silent chest.
Okay. Silent chest on auscultation if you are not getting any aerometry. Other thing is that always don't blindly follow the SO2 alone. Because what happens is the patient might have a saturation of 96, but the oxygen requirement might be going up on the other end. Okay, the patient initially might have been on 96 on 1 liter of O2, but at half an hour, if you are just saying that it's 96, it need not matter. The patient might be requiring 15 liters of O2. Okay, so go by PO2 by FiO2 ratio for assessing hypoxia. Don't blindly follow the saturation alone. Okay, so these will be the indications for an impending respiratory failure. So suppose you are planning to intubate this patient. So what are the extra things which you need to consider apart from a regular kind of scenario?
As it is, childs are have to know the size of the cuff. You have to look for the blade size. Then the from the usual intubation, we won't be flexing the neck like in adult. We will be doing it in a neutral position. Then
adult also will do it only in neutral position, not sniffing position.
Sniffing position, sir.
So both are same. Neutral.
So pediatric airway is different from adult
Adult
airway.
airway.
So these changes has to be looked into. One child can have a big head, large occiput can be there, shorter neck. Then the narrowest part in a pediatric airway would be
That
the
is
vocal
in
cord.
small babies less than 2 years. So what she said, how will you manage? Like
You
flexion?
can place a shoulder blade, you can place
Small towel behind
Towel,
the
yeah. Should
shoulder.
not be too much height also. Just 1 inch, 2 inches. Just entire shoulder, down the shoulder. You have to give it. So the neck will be there. Carry.
Their larynx will be placed anteriorly, and then they'll have short neck. Apnea time is less, so the child can go into hypoxia. They're not very resistant to hypoxia. So then
So how will it be manifesting? Hypoxia will be bradycardia. Most important. The cause for bradycardia, don't immediately rush for atropine. correct the oxygenation, it will be settling down. Okay.
So one thing is big head, then large tongue, then the visions and this thing. All air will be more narrowing towards the as we progress. Then the child may have large adenoids and all that, and also the apnea time will be less. So we have to keep
So if it is adenoids, what precaution we have to give?
positioning.
That will be obstructing the airway. So mostly a smaller
Small size tube should also be.
basically difficult airway.
No, pre-oxygenation itself will be difficult. So only maneuvers cannot help. We have to go for a
OPA.
OPA, oropharyngeal airway, ought to be, must. Otherwise we cannot pre-oxygenate. Good.
So these will be the pediatric airway changes. So this has to be kept in mind.
And then what is the epiglottis?
Epiglottis will be larger.
Long. It's long and so you told anteriorly placed the larynx. So when you are doing the laryngoscopy, how it will be overcome the
The
difficulty?
thing is, usually in adults we place the tip of the scope in the varicula, but in this we have to keep it underneath the epiglottis and lift the whole epiglottis up.
That is it, straight blade.
Straight blade.
You always change over to the straight blade.
Straight blade.
And then go step by step, slowly. See, suddenly you will be past most of the blade inside. Then you will see only the esophageal orifice and by mistake you will take it granted it is the so you have to go slowly, step by step. Then you will see the epiglottis. Then you go under the epiglottis, lift it. All these things, okay.
They have to be adequately pre-oxygenated before we attempt intubation. And difficult airway has to be kept. This entire set has to be kept ready because pediatric airway itself is difficult airway, and then patient has to be kept on a continuous monitoring for and washed out for bradycardia, and the early intubation as a mainstay of treatment. Then medication doses also vary. All the crash medications have to be kept ready.
Also, always keep a 2 or 3 size tubes above and below because the size we are not expecting the same will be there. And also, after intubation, we have to always make sure the tube is not kinking because it's a very small diameter tube. So we have to make sure it is not kinking. And also, if the tube length is a bit too much, we can even cut the tube to reduce the total airway length.
Cutting this other
Cutting the end, and we can keep it just above the mouth.
prevent the kinking.
Prevent the kinking.
They can have more secretions also. So everything has to be calculated. So like starting from the size of the tube to the depth of the tube, then auscultation, and it has to be like frequently checked. For the air entry has to be frequently checked because dislodgement of the tube is more common in pediatrics, and then all the tubes.
So drugs selection. Drug selection. Before that, what are all the factors that will trigger autonomic stimulation, especially parasympathetic stimulation? So what will happen parasympathetic stimulation?
Bradycardia.
Not only bradycardia, broncho. What will happen? Bronchoconstriction and then laryngeal spasm. So we have to avoid it. So how can you achieve this one? Anxiolytic plus
Okay, atropine give it atropine as a
analgesics, fentanyl. See, the procedure itself will trigger, not necessarily parts of tube. Laryngoscope itself goes and touches the oropharynx or epiglottis. All areas are richly supplied by vagus. That will trigger. Bradycardia you have to monitor, and then suddenly the child may go for laryngospasm or bronchospasm. Laryngospasm difficult to intubate. You can't visualize also. That you have to keep in mind. So how will you avoid anxiolytics, and especially adequate analgesia, short-acting fentanyl, like that. So after that, induction agents. What are the induction agents?
Ketamine.
Ketamine.
In this case, it will be beneficial because
She already
it has an added
tachycardia.
bronchodilatory effect.
Bronchodilator. Any other drug in the induction agent?
Etomidate
can be given.
The best is propofol. Propofol. Unless there is no hypotension. So propofol is not having any analgesic property. Ketamine has got both analgesia and analgesic as well as anesthetic. Here we have to supplement pre-hand. Adequate fentanyl we have to give it. Don't give minimal dosage of fentanyl in such cases, which triggering of the autonomic nervous system will have impact in such cases. Okay. And then muscle laxants of choice.
non-decolonized.
Rocuronate.
Rocuronate.
Succinylcholine also can be used.
Okay. So any other drugs in the armamentarium which produces Histamine release also we have to avoid.
Triglyceride.
And sir was telling, see the respiratory distress patients, they go for increased level of carbon dioxide. Why? How it happens?
Because inadequate ventilation.
Inadequate. See the muscles all overacted already, overstrained, exertion.
Fatigue.
They are coming fatigue. So slowly the hypoventilation starts. So carbon dioxide elimination will not be there. Best monitor is the ETCO that you have to keep in mind. Okay, sir.
One thing probably which we can give early if the patient is, you have realized that the patient is in respiratory failure or impending respiratory failure, will be IV steroids. Okay, so pre-intubation also it can have effects. So now the patient is intubated. So what are the usual ventilatory line of management and what are the complications you are expecting, especially in a pediatric patient with bronchial asthma?
Asthma, basically, there will be entrapment, development of autopeep. Hyperinflation of the lungs is the main complication that will happen. And if at all patient develops autopeep, we can see it on the waves in the ventilator. And at that point in time, we have to disconnect the ET tube from the machine for a couple of seconds and then reconnect it. So this is how we'll tackle autopeep. As far as tidal volume is concerned, it has to be between 4 to 8 ml per kg of the tidal volume has to be achieved. And then high pressure can cause barotrauma. So pressures have to be basically low pressure ventilation is what is preferred.
Yeah, so basically it's low pressure, minimal rate, minimum volume, but adequate inspiration with a prolonged expiration. Okay, and watch for autopeep as she told. And other key thing is that make sure that the child is adequately sedated. Okay, you don't want any dysynchrony to be popping in. Okay, so these are the key things we need to remember in a patient who is already tubed and being ventilated.
What is the pathology in bronchial asthma?
Basically, it is the inflammation of the airways.
One is inflammation. Okay.
Second is hyperactive airway.
Pardon, hyperactive airway. Inflammation will cause what? Three things are there in the bronchial asthma. See, one is inflammation. What will happen to the cells? They will become edematous. So the children, the passage is very narrow already. So this edema will produce, what will happen? Again, this will become very narrow. Second one is increased mucus production, secretions. That will again add fuel to obstruct the airway further. Third one is
Hyperactive.
bronchospasm. Okay, bronchodilation and bronchoconstriction. That is what happens. So when you are going for a therapeutic this thing, so directly we are giving bronchodilators. So many times the recent concept is it is not reaching the terminal smaller bronchioles. So unless otherwise these bronchioles are dilated, oxygenation and carbon dioxide elimination will not be possible. The first line they told, first give steroids. Sir was telling two ways. One is the edema part, inflammation will be reduced. Number two is it will protect the laryngeal edema formation also. So first line you give parenteral or inhalation if possible, oxygenation. Then along with that parenteral works out very fast. So otherwise you can give inhalation also. After that you give the bronchodilator. So in between you clear the secretions. So then we will administer the bronchodilator. So that will be working out very well and quickly the patient will recover. So one more thing, mucolytic agents. So it loosen the secretions and make the secretions very thin so that we can even suck it out. Otherwise thick secretion, suction may not be helpful. So, and expiratory pass, then this should be prolonged expiratory pass. Even before pre-oxygenation or planning for that, rule out any tension pneumothorax and pneumothorax. So once you are putting it in, we are going to do the IPPV, positive pressure ventilation. That will worsen the thing.
Can you use meter dose inhalers on an intubated patient?
Yes.
How?
Connected.
Yeah, so we can, it need not be always inhalational, through nebulizers only. You can connect and separate adapter to the expiratory end, and through that you can give MDI where you, of course, the onset of action can be a little more quicker than the conventional nebulizations. Okay.
That will increase the dosage. When you are giving through the circuit, you can give additional 1 or 2 puffs. So that will have to entire circuit it has to cover. That is the other thing. And when the patient is in, you can have a conscious before giving induction agent itself, metered dose inhalation. You can ask the patient himself to take one, regular one, additional this thing. And what will be the effect the patients are on long-term steroids, metered dose inhalation? Whether they are coming for any other problem, whether they need to supplement hydrocortisone. So usually they say metered dose inhalation of the steroids. That doesn't affect the
Systemic.
cortisol levels. So only parenteral administration or long-standing tablet forms that will have an impact. Okay.
Also, acute emergency, we can even give the MD the child already is using about 2-3 times adaptable dosage. Like if the child is taking 2 puffs regularly, we can give like up to 6 times. It's an acute emergency. We're not able to quickly arrange for nebulizations in EDs.
So many of the time the problem is we are straight away giving the bronchodilator. We think without taking care of the edema part and secretion part.
Preferably give budesonide or something initially first to relieve the edema, then give dilators like Asthma or something as second.
So you should know nebulization, what is the particulate size at the end, what is the size of the terminal respiratory bronchial size.
So as recommendation, actually we have to give the oxygen supplementation of nebulizations always we will give to a child, and the range should be between 6 to 8 liters per this thing. Then only we can get the correct particulate size so that it reaches till the end of the alveoli.
And that is
So in giving nebulizations, we have to keep a range between 6 to 8 liters.
Minimum.
So that the particulate size will be adequate.
Yeah.
And that should be it. Anything else?
So basically, if a child is coming, we have to like immediately assess the child whether the child is like in a stable, like a green category, or intermediate, or like an impending respiratory failure state. So the initial assessment is so we can ask the caretaker, whether it's the mother or whether it's the caretaker, like ask them how the child was before and how is she now. Like answering their opinion, like is the child appear to be too sick or not, we can ask the caretaker so that we get an idea regarding to this thing. And also on the initial impression, so the child is like in an altered sensory state, the child will be going to the class 3, is in the red state, the impending respiratory failure state. The child is like in our state, like an active cooperative child, obeying commands and everything. That she will be in a bit more stable green state. So we have some more time to assess the child. So in case of a probable red category, we have to immediately, parallel to our initial management, we have to arrange for all airway maneuvers and everything side by side along with our initial care. So I think the start will be like be possible provide nebulizations of whichever is early available as early as possible. If not available, we have to give oxygen supplementation initially. Then start with nebulizations of steroids and this thing bronchodilators. And by part, we can all assess if we're not able to assess to get the age or weight of the child, we can use a Brosler scale if available and get the recommended medications and tube size everything ready by the initial stage itself. And also this thing, if you're not able to like get a proper IV line or anything, we can give like oral steroids are also like we can give it. So prednisolone we can give 2 milligram per kilogram given as an initial dosage in ED itself for acute exacerbation. Or if you're able to get an IV line, we can give 1 mg per kilogram of methotrexate as a bolus during the acute exacerbation state. Along with that, we can give either nebulizations or the whichever MDA the child is using as about 2 to 3 times the dosage. And again, if this is going into impending failure, we have to plan or go for early intubation. Like other than in adults, we wait for some more time. So better to not to wait in case of a pediatric child. Go for early intubation or planned like intubation will be much more preferable in child than this thing. And also, a child usually less than 2 years of age, we cannot term it as asthma. It's more probably it's a bronchitis or maybe like a foreign body or something. So whichever is the management will be more like a same pathway. We give adequate oxygenation, bronchodilator, and stabilize the child. And also, if she requires like fluid resuscitation, also nutrition should be arranged. So we have to get an IV, second IV line. If the child is appearing to be dry or like in a dehydrated state, we have to get an IV line. We have to give adequate nutrition, adequate hydration, along with that oxygenation and other hemodynamic support. And also this thing, if it is a diagnosed case of asthma, while sending by the child, we can go in a GINA guidelines pattern. So initially, we will be like giving only a single a bronchodilator with a low dose steroid. But as the requirement goes up, we have to go for a moderate grade steroid, or maybe even initially we have to give a short supplementation of about 4 or 5 days of oral steroids, and along with that like a bit more higher dose of what the child was taking during the initial course, then titrate on the second visit. Then we will go in a step ladder pattern. So initially, a low corticosteroids and single short-acting bronchodilators. Then we go for long-acting bronchodilators and medium steroids. Then we go for high steroids and longer acting dilators. That will be the pathway.
Short acting, immediate action. Long acting, action will talk time.
So this child is more coming in a green category with some early respiratory distress. So we initially managed with nebulizations, and also she had some mild inflammatory elevated markers. So we started her on antibiotics also. She was initially observed for some time, admitted for 1 day, and then discharged. But she was hemodynamically stable. She didn't go to that yellow-red phase. So
Usually for acute exacerbation, antibiotic is not needed unless you have a very strong indication of an infection in a child. Okay.
So, asthma is more like a reversible condition.
Yeah, if you have an X-ray evidence or something like a pneumonia or very strong evidence from other inflammatory markers, then probably it is indicated. Like usual term, it's not indicated. Yeah.
And you can even avoid ABG on the initial phase if the child is responding quickly to the bronchodilators. Because our asthma is more like a reversible condition, so usually they quickly respond to early initial management.
Asthma has a grading. It is moderate, severe, life-threatening, and near-fatal. So the entire management depends on which category the patient falls into. So they ideally have to categorize the patient, say it as a moderate exacerbation, severe, life-threatening, and near-fatal. If it's a near-fatal, then the only difference of near-fatal is PCO2 retention will be there more than 45 is when we consider intubation. Other than that, life-threatening also is like watched and then we intubate. And for severe and moderate, it is through, first we go with beta-2 agonists. After that, we add anticholinergic nebulizations and then low-dose steroids, then high-dose steroids. And then IV magnesium sulfate also can be given, even though nebulization of magnesium sulfate does not have much role. And then more than 3 years of age, we can even give IV aminophylline also. Basically, depending upon the grading is how we approach the patient.
Okay, very well summarized. We'll stop. Okay, thank you.
Thank you.
Thank you.